Welcome, everyone. My name is Brooke McNaughton. I am the Main Care Quality Manager. And I am pleased as punch to welcome you to the first in a series of webinars that we are hosting for the primary care plus quality measures. There's a lot of crossover in the quality measures that we have in the different programs. So if you're joining us from a different program, welcome, welcome. We're happy you're here. But the first in the series is on lead screening. Today, we're going to be giving a brief introduction to Primary Care Plus just to set the stage, making sure we're all in the same place. We'll have our dear partners from the Maine CDC talk to us about the value of lead screening, the why we care about this as a measure. We're also joined by the incredible Dr. Van Wagenen to give us some lessons from the field, some of the improvement efforts that she's been able to find some success with. Finally, some really quick, a tip sheet, tips for improvement on the measure and in practice, how we are having processes, both billing and within the practice. And then finally, the nitty gritty of the measure specifics, which fortunately is not too granular. It's a pretty straightforward measure. So let's go ahead and get started with the introduction. I'm going to pass it over to the operations manager for the delivery system reform unit here at Maine Care, Loretta Dutil.
Great. Thank you so much, Brooke. As Brooke mentioned, my name is Loretta Dutil. I'm the operations manager for the delivery system reform unit, which also includes Primary Care Plus. And I just wanted to provide just a brief overview of Primary Care Plus, just to sort of level set a little bit before we dive into the lead screening discussion. So Primary Care Plus started back in July of 2022. The goal of the Primary Care Plus program was to incentivize that whole person approach to healthcare, and also connecting patients to care that meets their needs, whether it's behavioral or physical health supports. This payment model also supports practice changes so that practices can better support patients and patient outcomes. As part of the PC Plus model, there are also performance measures for all of PC Plus practices. And you may have noticed that we have been sending out this data quarterly to practices. So this webinar really is a great opportunity to do sort of a deep dive into one of those measures today. As you know, we'll be looking at the lead measure. This is both a performance measure for PC Plus and also one of the covered services that PC Plus practices must provide. So this topic is definitely well aligned with all the work that PC Plus practices do. So happy to have you here. With that, I will turn it over to Brooke to talk a little bit more about the quality measures within PC Plus. Oh, you're on mute, Brooke.
You know what? It does not matter that we have been working remotely for years now. I still always do that at least once a week. So I did want to mention before we get rolling that if you do have any questions, please put them in the chat. We may get to them later in the conversation, but it's good for us to know what's coming up for you. So as Loretta said, we do have quality measures we look at in the Primary Care Plus program, and our policy has limited it to no more than 10 quality measures. This is a list here, but when you get sent the slides, this is also a hyperlink that will send you to where you can see them. If they ever get updated, you'll be notified. Right now we have 9 listed. Most practices are eligible only for about 8. You get sent quarterly reports. If this is news to you, you're probably not the person who receives them. I would ask around and figure out, you can ask us who we're sending them to. Each practice gets sent a quarterly report, letting you know how you did on each measure. So here you see this is a little snippet from Pretend Pediatrics. I got real creative with the naming. And up at the top, we see that you can confirm who you are. What's important here is the measurement date range. This is where we're looking at the specific measure we're going to be talking about. This is when we pull that data. And then you can scroll over. This is hyperlinked too, so you can get to see an example linked online. So you can play with it and see how it works when you get the slides. But you scroll over to lead screening and you can confirm, well, what is lead screening by definition. And then of note right here, minimum denominator required for the measure to be counted toward PBA, and we'll talk about PBA. The denominator that we use, this was informed by a healthcare statistician, is 30. So you only get your performance counted toward your PBA if you have at least 30 kids who turn 2 within the measurement period. And so just wanted to give you a little brief insight into this. Right, so you have 10 quality measures, no more than 10. You have your quarterly reports, and then the quality measures inform your payment. So the performance on your quality measures informs payment via something we call PBA. That's performance-based adjustment. We're working toward implementing PBA, and how PBA is calculated will be the subject of a future webinar. It's not something that we're covering today. So the takeaway, better quality performance means better care for patients and a bigger payout, bigger PBA. And because of that, this series is intended to help you get there. We want to help you with your quality performance. We want to educate on best practices so you can optimize your performance, your payment, and help both population and patient health. You can expect one webinar a month during this year, 2025. And please do sign up for e-messages to stay tuned. Cheryl, if you're able to drop the e-message link in the chat right now so folks can make sure that they're connected, that would be excellent. So we're on to the next section of our agenda, the value of lead screening in children. I'm going to pass it over to Dr. Maggie Bordeaux from the CDC to take it from here.
Thanks so much, Brooke. Hi, everybody. Good afternoon. Thank you so much for being here and sharing your lunch hour with us. I am the public health physician for the Childhood Lead Poisoning Prevention Program. I'm also a practicing pediatrician, so I understand on a day-to-day basis what it takes to get lead testing done, convince patients to get it done, share the results, etc. So I'm always a resource for anybody who has questions. In the slides, it does include my email, so please, 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 anything that comes up for you around anything lead testing, lead questions in the future, please feel free to reach out to me via email with anything, and I will get back to you. So I'm going to talk a little bit about just lead screening in general. Go ahead, Brooke, you can go to the next slide, please. So I always like to start my talks with providers and practices about why do we do this? Because as Brooke just mentioned, this meeting is hosted by MaineCare, which focuses on quality measures. The purpose of that, as she mentioned, is really because we want to provide better care or more complete care to our patients and families. The reason that we choose to work in healthcare is because we can make a difference. And so I try to remind everybody about why are we still talking about lead? Why is it still here? And what is really the big deal? Because even I, before I took this position, would say, no, about that lead level, yeah, it's probably fine. Let's go back, get it repeated. I'm sure it'll be okay. And as I do this work now every day, all the time, it's much more salient and much more in my face. And so I just want to remind you why we are still talking about this. So the health effects of lead that we see most commonly are really developmental effects for children. So lead is a neurotoxin, and so it goes when the body absorbs it and it gets into the blood, it is absorbed by the brain, and it does irreparable damage to the brain, unfortunately. So those are not necessarily things that we might otherwise think in terms of brain injury, like concussions or causing seizures or things like that. And a lot of the health effects we may not even see until children are school age. So they may have difficulty with math, they may have difficulty learning to read. And younger children, they may have difficulty with handwriting, using their hands to do different things, learning to speak. So these are all a consequence of being exposed to lead. The magnitude of the consequence is often dependent on the duration of the exposure, how old the child was at the first exposure, the amount that enters the body, and the amount that's absorbed by the body. Over time, this adds costs to healthcare because of repeat testing and visits to the practice. It also affects school and children needing an IEP or extra services ongoing. And then it has huge effects to our overall economy, because what happens is these children become adults who they're not reaching the potential that they otherwise would have had they never been exposed to lead. So we're really, this is a multi-million-dollar, billion-dollar effect on our economy from just the small amount of lead that these children are exposed to. So that's why we do what we do. Now I'm going to dive in a little bit more to the data and to the law. So in 2019, a law was proposed because we had been pretty stagnant in terms of lead testing throughout the state. And the only way we know right now if children have been exposed to lead is to test the child. So unfortunately, this is a little bit of a canary in the coal mine scenario in terms of how we learn about children who have been exposed to lead and have lead in their blood. So in 2019, the legislature approved a measure that mandates that all healthcare providers test children at both 1 and 2 years old. So it's not just at 1, it's not just at 2, it's no longer just screening and testing children who are at risk, it's all 1 and 2-year-olds. Historically, Medicaid has always recommended that children who have Medicaid for insurance or MaineCare be tested for lead because children with Medicaid and MaineCare are a higher risk population. And the other factors that it's not just obviously that they're on MaineCare for insurance, it's that these children are living in poverty a lot of times, and then they're also living in older housing. So just remind everybody, the biggest environmental health issue for children in the state of Maine is lead exposure, and that comes from lead paint and lead dust from older housing. Next slide. So we have a lot of data, interestingly, and this is really exciting. I think I'm a little bit of a data geek, and so anybody else who is a data geek, the Maine Tracking Network is a great place to look if you want to learn more about more details about the lead in your area. We have county level data, state level data. There's other information on the Maine Tracking Network, things like Lyme is tracked there, as well as carbon monoxide poisoning. So it's a really interesting place to go and look around if you're interested in data on a few different public health issues in the state of Maine. And there's a hyperlink at the bottom of this slide where it says in blue, the child lead poisoning Maine Tracking Network, that will bring you right to the Maine Tracking Network site, right, just specifically to the lead poisoning piece. Next slide, please. So this slide, is again from the Maine Tracking Network, and it shows the lead testing data for the whole state, and it shows the data for all insurances or children without insurances here in the state of Maine. So you can see that there's a little bit of nuances to the data, but basically 1-year-olds or children who turned 1 in 2023, 77% of those children were tested for lead. And for the 2-year-olds across the state, unfortunately, have a lower lead testing rate. And we have some theories about why that might happen, but we're not exactly sure. We're undergoing some, looking at some data and doing some studies about why we think 2-year-olds are tested less. But if you have thoughts from your practice, please feel free to share those with us. And then the last measure that's on this slide, this is the purple line at the bottom, are children who are tested at both 1 and 2 years old. So because our law in the state of Maine says it's a universal testing law and says that children should be tested at 1 and 2 years old, we're trying to figure out how often that is happening. So as you can see again on the bar graph, you see at the top, the darkest blue line there are the 1-year-olds, the light blue line there are the 2-year-olds, and you can see the difference in percentage-wise, it's a 25% difference in those two age categories, again, which we would really like to narrow that gap. And then the 1 and 2-year-olds, again, are below that level. And we hope to see that continue to increase over the next couple of years. Next slide. So here's where we need your help. And this is why this has been a really great collaboration for our team to be able to work with the MaineCare team and have them support us and our lead testing initiatives through hosting webinars like this and e-messages. That's been extremely helpful because we're really trying to change the story for the population of children who have MaineCare for insurance. So here, this is the stark reality of what's happening across our state. So for the 1-year-olds, you can see that those who have MaineCare for insurance are tested at about 61%. Whereas children that don't have MaineCare, so all other insurances and hypothetically children who are uninsured, are tested at 94%. The good news on this slide is providers can do a really, really great job with lead testing. So 94% is a really astounding number. The other thing that you can see on this part of the slide is how flat the line for children with MaineCare is. We have not really been able to move the mark since 2019. And you can see that between 2018 and 19 on the graph here, you start to see the testing rates rise for those children who don't have MaineCare. So we do recognize that there are a lot of barriers to children who have MaineCare for insurance, and we're trying to really figure out what is preventing those kids from getting a test at 1 year old, in contrast to all children who don't have MaineCare for insurance. For the 2-year-olds, again, thanks, Brooke. For the 2-year-olds, again, similar story to what I was talking about in the last slide. Overall, the rates for 2-year-olds are lower than the rates for 1-year-olds. And again, we think that that is happening because at 1-year-old, parents are coming into our offices a lot. There are frequent visits for well child care, and we think that providers are able to capture those kids when they're in the office, getting their well child care, getting their vaccines, and that's where they're getting tested. At 2 years old, the frequency of well visits is less, and it may be harder for practices to know who has and hasn't had their lead test for 2 years old. So we think that that's the difference between 1 and 2-year-olds. Like I said, we are investigating that at this point in time, looking at the data, trying to confirm if that's actually what's happening, and then that will help us really target that 2-year-old population. So for the children with MaineCare for insurance, we see about 50%, about half of the 2-year-olds with MaineCare are getting tested. And then it's higher than that for children who don't have MaineCare, but again, still less than what those 1-year-olds are, like we saw in the first slide. Okay, you can go to the next slide. Okay, so this, I just want to talk a little bit about the ways that offices can get a lead sample. So blood lead screening can be done through a capillary or a venous test. So the capillary is, as shown in this picture on the top, it's a finger poke or a toe poke, depends on where you are and how you've trained your staff. But basically it's something that can be captured, and then that screening can either be done using what's called a LeadCare-2 analyzer. That is a point of care testing device, or a capillary sample can be drawn in the practice and sent to the Health and Environmental State Lab or the Maine State Lab. Both are equally effective in terms of the number that you get. So we actually had a couple practices across the state who have a LeadCare-2 analyzer, a point of care test, and when they first started using it, they were a little unsure of how reliable the machine was, and so they would draw both a LeadCare-2 sample and a capillary sample that they would send to the state. And generally what they found in comparing those two was that the results were very, very similar within a few decimal points of each other. So that's one methodology that can be used. But due to the potential for contamination, or the fact that lead can be on the skin, we always recommend that if the lead level is 3.5 or higher, that child gets a venous blood lead level, which is more challenging to convince parents to go to the lab, because most of the offices across the state, that parent and family have to actually leave your office and go to a different location, even if it's in the same building. I've had parents tell me, like, I know that I was supposed to go across the hall to that lab, but I was not doing that after my child got 3 shots and was screaming and it was nap time. So we know how challenging getting those venous lead levels can be. But the really important thing about that venous blood lead level is that's the only way that child and family get access to our program. Okay, let me say it this way. That is the main way that those children will get services through our program. There is another route through doing a home lead dust kit that families can access, but generally the way that they get involved with our program is that they have a venous blood lead level that is greater than 5. Just a little bit of a nuance, the 3.5 and higher is what's called the National Blood Lead Reference Value. That is what the national CDC recommends follow-up for. Our state statute still considers lead poisoning at the rate of 5. Right now, between 3.5 and 5. We are starting some initiatives that will send home lead dust kits to families. You are welcome also to tell families that they can do a home lead dust kit. And we have a website that's very easy for them to sign up. And if that home lead dust kit comes back with elevated dust levels, then we will also offer them full case management services. So again, take home for this is that capillary tests are usually the first test that is done for children, but if the result comes back 3.5 or higher, they really need a venous blood lead level done, because it may just be that we're catching them. If the venous comes back less than 3.5, but the capillary was at 3.5 or higher, that likely means that that child is being exposed in their home, and we've captured them at a time when that lead has not yet made it into the blood supply. So it's a really, really important time to give some advice to the family on lead prevention and make sure that we're following that child really closely. Next slide. So this is the venous confirmation testing that's been happening across the state. This is really important. Again, the screening test is what gets captured for main care to kind of check that box in terms of lead screening. But again, the reason I'm sharing this is that in order to get case management services for your children and families and your practices, they have to have that venous blood lead level. And so what this slide is showing you, the different color lines are the different blood lead levels. So the blue line is a capillary blood lead level that is 3.5 to less than 5. The red is a capillary level 5 to less than 10. And then the green is a capillary blood lead level that's 10 to less than 15. There's no reason that there should be any difference in any of these lines. So every level needs that's listed on here needs a venous confirmation to really know where the lead is, if it's just on the surface of the skin and we're preventing it, or if it's actually already done damage to the child's development. So I guess I would just really encourage you that all lead levels are important. Any lead level, even the really low ones, have been shown in scientific studies to have poorer outcomes, or those children have had poorer outcomes than children who are not exposed to lead. So really, really, really important to get that venous confirmation. And the good news from this slide too is that, and the reason we see some uptick between 2022 and 2023 is one, on that blue line, that is actually when our state guidelines changed to include blood lead levels of 3.5 to less than 5. So we've seen a really nice increase. And for those of you hopefully are familiar or have seen, we have had a process, what we call our courtesy reminder, where we send out to practices every month a list of children in your practice who are either due for a confirmatory test or they need a repeat test. We've had to pause that initiative for a little while we switched over to a new analytics system within our program, but we do expect in the next few months that we will be sending that back out to your practices so that your practices can reach out to families, remind them that they need to go for these venous confirmation tests, and get them back in there. We know that in my experience, most of the time, practices have ordered the test, they've told the family that they can go, but life gets really busy and gets in the way. And so these families forget that they have to go, or kind of we're hoping that they maybe didn't have to go. And so a little reminder and a nudge for them to get back into the lab can be really helpful for them. And so we think that that's where we've seen some of this good improvement in confirmation rates over the last couple of years. Next slide, please. So this is also really good news, and I want to thank all of you out there who do order lead tests for any of your children. This is one of the things that really has connected me to this work, and I just get very, very excited about it. Dr. Shah, who many of you remember from being the CDC director during the pandemic, will highlight that blood lead and the public health efforts around lead levels in the last 20 years are one of the greatest public health successes of recent history. So you can see that evidenced in the last 20 years of blood lead levels in children throughout the state of Maine. So you can see the percentage of children with a blood lead level. Again, this is for 5 and higher. So any child that had a blood lead level of 5 or higher, And this is the estimated percent was 8% of children back in 2004, down to 1.6% of children in 2023. So remarkable, significant change in a 20-year time period. And again, really great efforts. Now we need a final push. We need to push through, hopefully in the next, say, 10 years or so, to get down to a place where we can really completely eliminate lead in the blood of children in our state. And again, at the top here, you can just see that the basic numbers of children that we're talking about. So for kids less than 3, again, it's not that only children less than 3 have lead in their blood. That's just what state statute is looking at, and that's what we track in our program. That being said, there are certainly kids 3 and over who are at risk for lead poisoning, and Medicaid also recommends that any child who's never had a blood lead level and is less than 3 also needs a blood lead level. So this is, again, kind of bringing those pieces all together. In 2023, just to give you a little bit of perspective, throughout the state of Maine, we had 260 cases of kids who had blood lead levels 5 or higher. So again, I realize in the greater scheme of things, you are likely seeing kids who have more kids each year that have food insecurity in your own practice, or obesity, or behavior problems. But this is the number that we're looking at across the state of Maine. And the percentage of that, like I mentioned, is 1.6% of all of our less than 3-year-olds. Next slide, please. So again, as I just briefly mentioned before, and I just wanted to re-highlight, for the levels, when the child has a venous blood lead level of 3.5 to 5, right now we are working on creating a program where we have somebody from our practice, from our program, who will reach out to parents if the child has a 3.5 to 5 venous blood lead level and offer that family a home lead dust kit. The families then hopefully will complete the home lead dust kit, and your jobs might be to encourage them to complete that dust kit and send it back to us. We want to understand if 3.5 to 5 lead levels are also coming from lead paint and lead dust. We assume they are, but we don't have any data on that anywhere in the country yet. So we need to collect some data about what the sources of lead are and how frequently it's happening. And once we have that data, then we can go back to the legislature and show them the data and ask them for more resources, which would then allow us to expand our case management services to children who have these 3.5 to 5 lead levels overall. Again, if the lead dust test kits show elevated lead dust in the home, that is a way that we can also intervene with these families. We can talk about what they can immediately do to decrease the lead exposure to their child, and any potential future children, which is also an important source. So for any family practice docs who are seeing pregnant women out there, that's also a great audience to be able to capture. But once we have that data and we know about the lead dust, then we will be able to expand those case management services to all of the children who come back with the lead levels between 3.5 and 5. I know that somebody put it in the chat, the link for the home lead dust kit. It's also a actually, maybe it's not, sorry. I'm just highlighting here. This is not a hyperlink. I'm sorry about that. But the home lead dust kit site is listed in the chat. So please feel free to grab that. You're welcome to offer that to any patient or any person who's interested in knowing if there's dust in their home. Or again, for any pregnant woman, that's a great thing for them to do before they do any renovations to make a new nursery or nursery space in their house. Next slide.
And then we do have a question. Would it be possible to have someone located in our office to send home with families that test within the 3 to 5 lead levels, or is it only able to be ordered on the website?
We are happy to explore that option. In the past, what we've found is that it's very hard to get these kits to come back to us. And so if the family does register online, or even if you register them online in your office, then we can track that a little bit better, because we could know where we sent it and we could keep track of it, and we could call the family and follow up on the results. Whereas if they're just in the practice, it's harder to track those kits. So certainly reach out to me and I'm happy to discuss that. We do have that for some of our community partners. Like our child development services workers have home lead dust kits that they can do with families. Some of our other community partners in the Lewiston area also have access. So Healthy Androscoggin has access to the home lead dust kits in their facility. So it's not a no, but maybe reach out to me and we can talk through it a little bit more.
And then we do have another question that I think we'll save for the tips for improvement section, but I will go ahead and also hyperlink it here when we send out the slides.
Thanks, Brooke.
Thank you.
So in just changing, so that's kind of the background piece. As I told you at the beginning, I'm also a practicing pediatrician, and in my practice, we do use the LEDCare-2 analyzer. Previously, we've had the LEDCare-2 analyzer, I don't know, probably for 5 years or so. And before that, my practice did do the in-office capillary draw with a finger poke, and we sent it out to the state lab. So just to tout the benefits of the LEDCare-2 analyzer, there is a smaller amount of blood that's needed than the capillary sample that gets sent to the state lab. And that's kind of a bonus. I would say that's what my clinical staff in the office said when kind of at about the time that we were switching over, that was one of the things that they liked. A capillary test in general, whichever one you do, is much more appealing to parents than to say, go to the lab and get a venous draw. I think I hear from providers not infrequently, well, if really we want the venous results, why aren't we just sending them for a venous test? I will tell you, it is completely unappealing for parents to go and get a venous blood draw with their 1-year-old. So it is much more appealing for them to at least have just a finger poke. They might still need to go to the lab to get that venous draw, but there's a large portion of children who will not need that venous draw. So if we can save them that misery, that is great. I will say that I have a little bit of an asterisk there to say that we have learned from doing a recent project with LEDCare-2 analyzers across the state that if practices still have to send their kids to their 1- and 2-year-olds to the lab to get their hemoglobin or their blood count, it's challenging to convince them to get the lead done in the office and then still go to the lab. I will say the flip side of that is if you do the capillary draw in the office, they might not need the venous level, or you can capture them as a patient and say, hey, this is why this is really important to go and have the venous draw done. I think providers have a big impact on the patient in terms of being able to face-to-face say to them, you need to go and have this done. And that's one of the benefits I love about the LEDCare-2 is I can walk back into the room and say, this is important. This is why it's important. I know it's not appealing to think about this, but can you just go right down to the downstairs to the lab and have your child's blood drawn, and we'll know, quickly, and then we can kind of talk through those next steps. So, and I think if you tell parents, look, this is why I'm worried. If your child has lead in their blood, then we need to pay even more attention to their development and make sure that they get some extra services, child development services, Help Me Grow, Maine Families, whatever it is that can get into the home and be really monitoring the child's development. And then you can also, this is one of our tip sheets on the slide here, what you need to know. Things like this that might be you be able to give to parents as a handout or link them to. I know not most parents are kind of leaving the paper behind in our rooms these days, but if you can somehow get these tip sheets to the parents and remind them about why this is important, I think that goes a long way. And then the last thing I'll just say, I know I've talked a lot about confirmation rates. Historically, that we saw increased rates of confirmation testing with the LEDCare-2 results, again, likely because you're able to say that same day, you need to go and have this done. We've seen those rates change, and they're pretty similar to the in-office capillary testing. With an expansion of our LEDCare-2 analyzer use across the state, we may see that increase again, but that's kind of what we know for right now.
And Maggie, if folks wanted to have these handouts available to post in their office, how would they get that?
I'll put a link in the chat when Dr. Van Wegenen is talking.
Thanks. All right, so we are at the next section in our agenda, some lessons from the field. I'd actually like to turn it back over to Dr. Bordeaux to introduce our next speaker, if that's all right, just because you are able to do a little bit more justice to an introduction.
Yeah. So very kindly, Dr. Van Wegenen, who is a pediatrician at Central Maine Medical Center, and she is going to talk a little bit about the successes that they've had in their practice. They have done a really amazing job with lead testing over the last couple of years. And so we're very excited that she was able to take a little bit of time out of her schedule to give another side and perspective as a practicing pediatrician on lead testing in her office and some of the things maybe she's heard herself from families or her staff in terms of lead testing. So thank you so much, Dr. Van Wegenen, for being here with us.
Oh, thank you for having me. Yeah, I'm excited to talk to you all about it. Brooke, you can jump right into the next slide when you have a moment. So we, well, this practice for years has been, I think in general, trying to follow the recommendations as they're written, doing the lead risk assessments, basically 6 months to 5 years at the well visits, and then also doing capillary lead screenings at age 1 and 2 well visits. And we were quite confident that every kid who came in for those scheduled visits was getting their lead screening done through capillary draw, and we actually send them to the Maine State Lab. So we were very surprised to find out that our lead screening numbers were not nearly what we had hoped they would be. So Brooke, if you don't mind, you can head to that next slide. So when we looked at our numbers in 2023, we pulled charts from kids ages 13 to 18 months to see if they had gotten their first lead screening test. And then we pulled ages 25 to 30 months to see if they had gotten their second. And we found that our for 1-year-olds that are younger range, only about 80% were done. And in the 2-year range, we had 64%. So we really felt like we were failing somewhere, and we weren't quite sure why, because between the providers in our office and our excellent MAs who room for us, we generally all remember it every time they're here. So we set a pretty ambitious goal for ourselves, especially for that 2nd-year screening, going from 64% to 87%. But we set a goal for 87% for both age ranges, and then kind of took the time to figure out what was going on. So Brooke, do you mind just going to the next slide? So when we looked back, we confirmed what we suspected, which was that every kid who was coming in for those visits was actually getting their blood drawn. So that was great. And it looked to us like the vast majority of the kids who we didn't have their lead screening test done were just because they either didn't have a well visit scheduled or they no-showed. But it was really that lack of follow-up on our end. And so the first thing we did was we ran a monthly list of patients who are 11 months and patients who are 23 months, and making sure that those kids had their well visits scheduled within the next couple months. And that really found quite a few patients who didn't have follow-up, who didn't have their well visits scheduled. So we were able to call them and get them scheduled, which was great. The other thing we did was we really shored up our no-show process. So if they didn't show up, instead of just trying once or twice, we kind of kept those on a list and would follow up with them more frequently to make sure that those patients got scheduled. So do you mind going to the next slide? So with those two things really alone, I mean, I would love to say that I could take credit for this, but this was largely the work done by our front desk staff team. Our completion rate by the end of the project went up to 93% for 1 year, 90% for 2 year. Was still the ones we're missing were kids who we couldn't reach, whether it's phone numbers not being intact, or families being away, or lots of different things. But we did hit our goal of 87%, and we were really pleased. Because to be totally honest, this was not a project that was super popular among my colleagues, because They felt like a lot of the failure rate we had was because it was more on the patient side than on our side. But I think what this showed was that there really is a lot that we could do as providers and as a team here to improve that follow-up. So it's not really completely on the patient side. There is a lot that we can do to help. You can go to the next slide. And so, like I said, deficiencies were nearly completely due to no-shows or not scheduling the next well visit. So we, and this has actually helped our office in a lot of ways, but really what we try to do is we make sure every patient that's checking out has an appointment scheduled for follow-up, which was something that everyone sort of knew was supposed to be happening anyway, but in reality wasn't. So, so even if they're coming in for an ear infection, the front desk staff is making sure that they have a well visit scheduled before they leave. And that's made a big difference. The other thing that's really come to light, which isn't really captured in this data, is that what I found is that we were missing a lot of those patients who had elevated lead levels and hadn't come back in for their 1 month, 2 month, 3 month redraws. And like Dr. Bordeaux mentioned, it was largely because the provider had notified the family that that the child had an elevated lead level and needed to have a blood draw done again in a certain period of time, had put in the order, but then there was no follow-up after that. We were just relying on families to remember to come back in themselves. And it was unfortunately not happening quite a bit. I don't have specific numbers, but just anecdotally, it felt like it was not uncommon for me to see this in a patient's chart. And so we're really working on making sure that those aren't falling through the cracks. So there are every office and every can have a different process, but what's worked well for us is that as soon as the provider notices that a lead level is elevated, we do immediately enter the order for the next lead level, along with any additional labs like CBC, ferritin, things like that. And then we also create a reminder within the EHR to prompt a member of our clinical team. And honestly, and what I do, because I'm so tightly wound, is that I create a prompt for myself. So in 2 months, I get a prompt saying that this patient's due for the repeat blood draw. I will then send a notice to the clinical to call and remind them. Will I also reschedule the reminder for 2 weeks from then to make sure that that actually happened? And then I'd say probably about 50% of the time in 2 weeks it hasn't happened. And so then I send out another notice to the clinical to call and reschedule my reminder. And it really has kept a lot of kids from falling through the cracks in that way. So I would not only work on making sure those follow-ups, especially at these critical years, are being rescheduled, but also make sure that you have a really solid system for making sure that these follow-up blood draws are actually being done. So next slide, Brooke, that might be it. Yep, that's it.
Thank you so much. I so appreciate that. And I can see that you already are getting some cheers in the chat. So thank you so much for sharing your successes. And also from a quality improvement standpoint, I was a little bit shooketh to see the 63 to 87% goal, but well done on exceeding that. That was incredible.
Yeah, thanks.
I'm going to pass it back over to Dr. Bordeaux to talk through some of the tips for improvement. And something I do want to acknowledge is that Dr. Van Wagenen mentioned something that was explicitly in the chat, a question about what do we do about folks who are no-shows, especially at the 2-year WellCare visit. That's something that I think that we might cover a little bit, but also we can save for the discussion at the very end. But I was really appreciative that that did come up. So Dr. Bordeaux.
Okay, so I think this is a nice slide just to summarize a lot of things that you've heard me say, and Dr. Van Wagenen really did a nice job calling out a lot of these things. And we did a little bit of a mini survey from some practices across the state who had really good lead testing results, like Dr. Van Wagenen's, to find out what they did to have those really good results. So again, the best way to do this is to capture the patient when they are in the office, first of all. So basically thinking about when children come in, is there pre-visit planning that's being done in your office? Are you doing huddles with your clinical team? Like Dr. Van Wagenen mentioned, are you running EMR reports to see who's due for a lead level? Those are all things that we realize are extra work. And this is kind of the new world that we are living in, right? With quality metrics and performance measures, is that this is true for a lot of these things. And for pediatrics, a lot of those quality metrics, performance measures, whatever you want to call them, are tied to well visits. And so things like vaccine catch up, et cetera, are all tied there. Getting well child checks in general is also a performance, not a performance measure, sorry, a quality metric for lots of different insurances. So if we can get them into the office, you're right, for whoever asked that question, if we can get them into the office, we can get these things done. But the other part is when we know they're coming in, how do we not lose them at that visit? How do we get that test done and know that they need it, particularly if they're off cycle? So if they're coming in at say 15 months, but they didn't show up for their 1-year visit, we need to know that when they came in, because I think I'll speak for myself. I'm used to knowing, like, okay, at the 1-year visit, they need their MMR, they need their varicella, they need their Hep A, maybe they need their flu shot, they need their hemoglobin, they need their lead. Check, 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 check. Like I know what to do at the 1-year-old visit, but when they come in at 15 months, I'm not thinking about the 1-year-old visit. So I just want to be able to make sure that, you know, we think about what did they miss in between, and if they missed their lead level, let's capture them while they're there at that next visit, at any next opportunity. Next bullet. Sorry, I guess I spoke about that as well. The other thing I'll say for this second bullet is a reminder that the American Academy of Pediatrics recommends that providers perform the risk assessment questions at every well visit between 6 months and 6 years of age, or through 5 years of age, I should say. And those risk assessment questions, I think, are things that you guys are all familiar with, but basically it's the 4 questions about age of housing, if the child spends more than 10 hours a week at a building that was built before 1950, any siblings or friends, playmates that have been exposed to lead, and any parents who have an occupation that may cause take-home lead. So those are the 4 risk assessment questions that the American Academy of Pediatrics recommends that everybody does at well visits. And that will trigger providers, or should trigger providers, to say, oh, this is a kid that actually does need to be tested, even though they're not here for their 1-year-old visit. Maybe they're there for their 15-month, 18-month. That's like a second layer of trigger. And again, back to running those reports for well child care, just like Dr. Van Wagenen's office did. That is probably how we get these kids in, because again, life gets busy, it gets in the way, we miss appointments, and then we forget to return that phone call to reschedule it, and it becomes really challenging for families. So the third bullet there is consider any method of in-office capillary testing. So you've heard about the 2 different methods today. I talked a little bit about the LeadCare2 analyzer, the point of care test, and Dr. Van Wagenen talked about the capillary draw, which gets sent to the state lab. So we've found, as I showed you in the data, or as I talked a little bit about in the data, generally either of those methods has really good results in terms of increasing screening tests. So there's a little nuanced difference in terms of the amount of blood and how you are getting and giving results. But that's, either of those methods are effective. And we have an initiative going on where we have looked at data from around the state, from practices around the state. And again, through another great partnership through our MaineCare colleagues, we have secured some funding to be able to provide some LeadCare2 analyzers to practices that have particularly low testing rates across the state. So if you are one of those practices that we have reached out to and offered this to, and you are here today hearing about these methods, we want to help support you with any method that you choose for your practices. If you haven't heard from us and you think that LeadCare2 is for you, feel free to send me an email and we can chat about any future projects that we have going on. The last thing I'll say for this tips for improvement, and again, Dr. Van Wagenen really pointed this out, and I just want to, I'm sorry I didn't include it as a bullet on the slide, but it's really, really important, is this is a team effort. So your front desk staff has to be on board, and your clinical staff, if you can empower them to really own lead testing, lead results, lead education, and really provide that, We know that clinical staff have increased joy in work when they are really connected to the patient. And lead is a perfect thing for them to own and have available. They can provide those tip sheets. They can provide the website addresses. They can say little things if there's not too much screaming going on during the capillary lead draw. Hey, I'm really proud of you, mom or dad, for doing this test with your child, because we really want to make sure that your child meets their full potential, and lead can get in the way of that. Something as simple as that really connects your team and the family together and really helps us know that we're doing the right thing for this child, and maybe makes that poke a little bit, like, resonate a little bit more with the parent in terms of like, okay, this is kind of a miserable moment, but I'm really doing the right thing. I think is that the last slide for me, Brooke? Oh, yeah. Oh,
I believe so. So we
I
are,
was ahead of myself. I did put it on the slide. Sorry.
you're excellent. Oh, did I? Oh, no,
Yeah.
that was on me. Sorry about that.
Okay. Sorry.
So we are at the last section of the webinar. We're perfectly on time. Thank you so much for sticking with us. What I'm going to be doing now is walking you through how it is that we measure your performance in lead screening in children. So I know that quality measures can sometimes be like a dirty word in practices. I know that I'm not everyone's favorite person because I try to implement quality measures, but what we try to do is select measures that are specifically reflective of the values that we hold at the department within the state, what we know is important for you as providers and for your patient population. And it's why I wanted to front end this entire conversation with the incredible work that Dr. Bordeaux does, with the work that Dr. Van Wagenen has done, so we can get a taste of the successes that can be had. Some quality measures can get really granular. I think very fortunately, lead screening is a more straightforward measure. So I'm going to talk to you about how it is that we assess your performance. Just keep in mind that I'm not talking about the report cards or the calculations for your payment. That will be a subject of a later webinar. And that quality measures can differ between payers. So I know a lot of payers do use this specific measure. It's from a steward called HEDIS, H-E-D-I-S. But the way that we measure it may be different than the way that another payer or that you measure it internally. The specifications are available to you. The agreement that we have with the measure steward is that we cannot just make them publicly available, but we can email them to you directly. So email us and ask for it. And then we're also working on getting them posted on the Health Pass portal. So it's behind a firewall later on this year. And then finally, if you want to do better with your performance and again, get better payment, following the Maine CDC's recommendations, those tips for improvement will help you there. So as a quality measure, we are looking at children who turned 2 within a measurement period and who had a capillary or venous blood test for lead poisoning by their birthday, so on or before. If they were, no shows up until, their second birthday, and then the second birthday they had their well care visit afterward, it would not count, which might be frustrating. It's kind of leads to the importance of being able to follow the CDC recommendations of getting multiple tests in, right? Not just waiting for the one. Again, we have your report cards. I had shown a preview of this earlier on in the presentation. And I'm not going to be going to the full link. Again, this will be hyperlinked so you can play around with a report card if you don't have access to your own. But we do use a minimum denominator. You can see over here to the very right of this image, this is our lead screening. You get the snippet of what it is we're looking for. And then the minimum denominator. So you'll still get your performance, even if your denominator, the kids that turn 2 within that period, if you only see like 20 kids or 15 kids, we're still going to show you how you're doing. It just won't count toward the monies that we give you. And so of the 32 kids that you see here that this pretend practice saw within this time period, of the 32 kids who turned 2 in that time period, only 10 received their venous or capillary lead test. So this is what the performance reflects. And that is what you are receiving with your quarterly report cards. So when you look at the specifications, the things that we send to you, this is what HEDIS sends us. We receive and accept CPT and HCPCS codes. And for lead, only the CPT code 83655. This is for the blood lead screening test. This is how we measure it. If you're not performing it in office, you can still get credit for it, right? If you don't have that in-office machine, the kids who are attributed to your practice, if they do in fact receive that blood test and it's billed within 3 months of the visit, then you still get credit as the provider for this performance measure. And again, it's only looking at the one code, CPT 83655. A couple things I did want to point out is that this is for the lead screen itself, not for a blood lead draw. You can still, of course, bill for the blood draw, but it doesn't count toward the quality measure. Maine does have enhanced reimbursement for blood draws for lead specifically. We do want to encourage you getting these in. And like I said before, credit for the CPT code is based on the patient itself. So as long as wherever you're sending them, as long as they go and it's billed within 3 months of the visit, you'll get credit for it. And the most surefire way of getting credit for it and getting that enhanced payment for the blood draw and getting, the reimbursement for the actual lead screen is by doing an in-office machine that Dr. Bordeaux has been able to walk us through. So we are rounding up on time. That was your quick and fast introduction to the quality measure that we use. And again, it's more straightforward than a lot of other measures because it's just the one code. So we are going to be wrapping up. A couple reminders. Please sign up for e-messages. It's how you stay in tuned or stay updated to the different webinars that we're doing. And you can also communicate with the CDC. We have more measure webinars coming up listed here: cervical cancer screening, breast cancer screening, well child visits. And just a reminder that this series is aimed to help you. So if you have any feedback, we'd love to receive it. We have 2 minutes for discussion. I would love to open the floor. And I know one of the questions was how to help with no-shows. Is there, let me look at the chat. And Erica, would you like to speak to this, or is there anything that you would be able to speak to Dr. Bordeaux on, or even Dr. Van Wagenen, on the way you can shore up some of the provider side of being able to help with no-shows?
Yeah, so we do see a lot of the 24-month physicals are scheduled, but then they don't come into their appointments. Sometimes somebody did respond that sometimes there are phone numbers that were disconnected and we're unable to reach the family. So I was just wondering how to maybe navigate that issue there.
Dr. Van Wagenen, do you have anything that you learned from recruiting in your practice, recruiting your PSRs to do a lot of this outreach, et cetera? Anything you figured out that helped with that issue?
And you know what, we may have lost her because we are nearing the end of the lunch hour. But
Brooke, I would just say
a quick suggestion. Sorry, this
please,
is
yes.
Kelly from OBH. If you could get like an alternative phone number, an alternative contact when somebody comes in, so not just an emergency contact, but maybe an alternative number that they could give you. So if you can't get a hold of them, maybe you could get a hold of the alternative number for updated contact information. That's just,
Yeah. Kind of like an emergency contact type of.
Yeah.
And then since we are at time, I do have to, oh, sorry. We are gonna,
I'll put it in the chat here.
thank you so much. Please reach out. We will send these slides out as soon as they are posted. So thank you so much for coming, and I hope everyone has a great rest of your day.